So this is a 41-year-old male, KPS 90. He presented to us with coccygeal pain and increasing urinary hesitancy for 6 months. An MRI lumbosacral spine with contrast was done outside AKUH on 22nd of October 2024, which showed a contrast-enhancing sacrococcygeal lesion. So we initially
Padma,
thought
please.
of it as a chordoma, and yes, uh, okay. So we initially thought of it as a chordoma, and that's why we took him for the surgery. He underwent biopsy of the sacrococcygeal lesion on 27th of October 2024. So we basically took him for surgery with the intention of doing maximum safe resection, but the surgery was abandoned due to significant intraoperative bleeding. The frozen section showed.
You can continue now.
Okay, so the frozen section basically showed malignant pathology. It was inconsistent with chordoma. So post-operatively, we got a CT cap done. That was done from AKUH on 31st of October 2024, which showed a sacral lesion with suspicion of deposit in the left paracolic region. And it also showed the suspicion of peritoneal mets. So initially, we thought of just postponing the surgery. We discussed the case in our tumor board at AKU, and we decided that the patient should go for a PET scan. And if the PET scan would report mets as well, then we should just go for chemoradiation, and we should not go for surgery basically. So we got a PET done. That was done on 14th of November 2024, which showed redemonstration of large hypermetabolic destructive mass arising from the distal sacrum with dense calcification and central necrosis. That was basically the primary tumor, and it showed morphologically stable sub-centimeter nodule in the left hypochondrium, and they said that it's most likely a splenule and not a basically metastatic deposit. So therefore, the patient underwent angioembolization of the lesion, followed by maximum safe resection on 26, consistent with mesenchymal chondrosarcoma. So just want to know the further
अब
management
आप
plan.
scans दिखा दें. You
Yes.
can,
Yeah.
Padma, please show the scans. Yes.
Yes, sir. So
Dr.
this was the.
Shomaila,
Oh,
please.
Ji, Assalamu alaikum, everybody. So
One.
if we start looking at the images, the first set of series which you have provided is T2-weighted sagittal images. And as I scrolled through these images, I couldn't find any T1 plain image in which I could appreciate marrow, but I think all are post-contrast, or the second one is pre-contrast even, the second in the series. Is it pre-contrast even sagittal? I think it is pre-contrast even sagittal. So I will start with T1 weighted images. So whenever we look at the marrow, we have to appreciate T1 weighted hyperintense signals. But if we reach in the region of sacrum, which is partly covered in these scans, we can see that there is a large mass which has an intrapelvic component as well as an extrapelvic component. The intrapelvic component is larger, and it is showing signals which are hypointense on T1 and not matching the rest of the normal vertebral marrow. So it's a large mass in probably midline, although it is partly covered and I can't say much. And then if I go back to T2 weighted images, the previous set of images which you showed, there we can see that again it is a heterogeneous signal intensity marrow. If you look at the bottommost part of the imaging section, we can see that there are few isointense signals and few T2 hyperintense signals which represent whenever we see internal areas of necrosis which are T2 hyperintense, that shows a rapid growth of tumor as well as the aggressive nature of tumor. And then there is a neurogenic bladder. If you focus on the pelvis, we can see that the bladder is extensively distended, although it is partly covered. So probably this is because of the nerve root infiltration in this region of the corda-equina nerve roots. So in midline lesions, in midline sacral lesions, the differentials are chordoma and chondrosarcoma. The age group is 40 plus, so I will keep chondrosarcoma in the differentials, and especially the internal heterogeneous characteristics. And it is involving the probably the sacrum, also distal part of sacrum, and probably the coccyx also, but I mean proper coverage is not there. So go back to the other set of images, please. The third in row are the T1 fat sat post-contrast images, and there is significant post-contrast enhancement of this lesion. on coronal these are coronal post-contrast images, and again we can appreciate that there is, there are heterogeneous signals. These are not are these T1 weighted images? I don't think so. Probably it is a contrast that is filling the bladder. I'm not sure about these are T1 or T2, because मुझे जो इसमें नजर आ रही है, मुझे नहीं ये पोस्ट कॉन्ट्रास्ट नहीं लग रहे, बिकॉज जो आप बिल्कुल लास्ट रो में देखें उसमें जो थीकल सैक है उसके अंदर सीएसएफ के सिग्नल्स जो है वो T2 पे वो हाइपर इंटेंस है ना, तो ये T1 पोस्ट कॉन्ट्रास्ट नहीं हो सकता, ये T2 स्टर इमेजेस हैं जो फैट सप्रेशन की होती है, इसीलिए हमें इसके अंदर इंटरनल एरियाज जो नेक्रोसिस के हैं वो ब्राइट नजर आ रहे हैं। अगर ये T1 पोस्ट कॉन्ट्रास्ट होता तो ये एरियाज हाइपो इंटेंस हो जाते और हमें इसकी पेरिफेरल एनहांसमेंट आती। So this is wrongly labeled. This is stir image, क्योंकि आपने thecal sac को या CSF containing या fluid containing structures को देखना है ना, इतना होमोजेनस कंट्रास्ट वैसे आता भी नहीं है। पोस्ट कॉन्ट्रास्ट पे आपको मिक्सिंग नजर आती है, स्पेशली न्यूरोजेनिक ब्लैडर हो ना जब बहुत डिस्टेंडेड हो, so you can't see that homogeneous mixing of contrast in the urine. So this is a T2 coronal image, and again I can appreciate the same signal. There's a large mass with an exophytic intrapelvic component. There are internal areas of necrosis, and there is infiltration of the spinal of the cauda equina nerve roots are also probably infiltrated or surrounded by this lesion. And the next line is T1 post-contrast axial, and I can appreciate that there is a lot of enhancement. So I would have given a differential of both. When the lesion is very aggressive, I keep meds and chondrosarcoma in differential, especially when it is after the close to fourth, fifth decade of age group. So these are my findings, and I can't appreciate any lymphadenopathy, although these are very limited images. And सिर्फ इसमें सिर्फ ये आपने axial जो है post contrast इसको आपने फोकस करके इस एरिया से लिया है डेडिकेटेड, बाकी सारे स्पाइन के कट्स में कुछ पार्टली मैस नजर आ रही है. So over to Shayan.
I completely agree with all the description. Nothing to add. If you have any large field of view coronal sequence to share.
Just have these scans.
ठीक है. So Fatma, हमारा question जो है, okay, so we have.
So this was the CT cap basically, जिसमें ये एक हमें suspicion बताया था left hypochondria में of meds.
Okay. Dr. Shayan, does it look like meds to you?
It's like a lymph node, and I would like to see other images as well, because they have reported as a peritoneal deposit, and some scrollable images would be helpful, I think.
Okay, ठीक. Dr. Shumaila, you want to add? Sorry. Fat.
I mean, इसकी सिग्नल्स बहुत, इसकी जो डेंसिटी है वो बहुत ज्यादा स्प्लीन से मिल रही है, बट एक स्टैटिक इमेज पे जो है ना वो कहना, ऑब्वियसली जिसने स्क्रॉल किया पूरा और इमेजेस देखे उसने मेरे से बहुत बेहतर देखा होगा. मुझे तो खैर बैकग्राउंड भी पता चल गया कि पेट पे भी स्प्लीन जैसा था, तो मैं बहुत बायस देख रही हूँ, इसलिए मैं कुछ नहीं कह सकती. बट इफ somebody would have scrolled through and especially having a sarcomatous lesion in the body somewhere, मेरा ख्याल है पेशेंट को बेनिफिट ऑफ डाउट दे के पेट करवाना was a very wise thing.
Okay. Thank you. Yeah, Fatma, you were saying something.
सर मैं सिर्फ ये कही थी कि मैं अभी फिर इमेजेस स्क्रॉल कर लूं, like zero view खोल के, if you say.
Yeah, if you want to. So now the question to the tumor board was like for the next step, right?
Yeah, exactly.
Dr. Asim, would you like to add? सर आपकी आवाज नहीं आ रही.
Am I audible right now?
जी sir. जी.
अच्छा, ठीक है. So that's the first thing, or the radiologic video is already described. So we also have the differential as well. So the first thing would be actually to have the biopsy report of that thing. That is very important. So whether we are, because the differential is chondrosarcoma as well as the other thing as well. So the first thing that would require to actually manage this patient further is the is the biopsy of that region. So further management can be decided accordingly.
सर हमने उसकी बायोप्सी स्पाइनल तो हो गई थी
Mm-hmm.
उसमें जी
So what was the biopsy? Sorry, I
फातिमा
missed that.
Mesenchymal chondrosarcoma.
Sorry, it is chondrosarcoma?
Yes, mesenchymal chondrosarcoma.
So when you're talking about the chondrosarcoma, the management of chondrosarcoma is actually the surgical management is the first step, because anything short of that thing, surgery is not actually a curative option as such. So the important thing here is actually the surgical resection. So if we don't have evidence of any disease elsewhere in the body, the primary treatment is actually the surgery. Um, and the further management regarding the further role of radiation therapy or the systemic treatment, it really depends upon the pathological finding and the surgical extension as well, extent of the surgery section margin. All this. Thank you.
And sir, if after surgery we have significant residual, and so in that case, is there any role of chemoradiation?
So when you're talking about the chondrosarcoma, so the management, so the role of particularly, I'm not from. It's very difficult for my end to actually comment on the role of chemotherapy. But as far as radiation is concerned, usually in the chondrosarcoma, radiation therapy is indicated after surgical excision, irrespective of the margin of the tumor. Um, because usually the chondrosarcoma is a high-grade tumor, though the sensitivity of chondrosarcoma to the radiation therapy is questionable. It's not very, it's not very sensitive to the radiation therapy itself. But that's why the surgery is the first option, so that we can actually do it. So when we offer radiation therapy, we usually deal with the microscopic disease. So in the microscopic disease, because it's grade 3 chondrosarcoma, definitely the role of radiation therapy is there to provide the local control. Uh, in the presence of residual disease or gross disease, yes, radiation therapy is still indicated, but the benefit is definitely is not what we expect in the complete resection. But definitely the role of the radiation is there. The issue
For
is
the
that
local
when
control.
for local control, definitely for local control, you need to actually offer radiation therapy. The issue is that for chondrosarcoma, this tumor require very high dose of radiation therapy. So if we look at the location of the tumor, usually the site where it arises is usually have a significant or critical organ at least surrounding by the tumor. So we have to actually limit our dose as well. So that is one of the obstacle in those escalation. But still, the behavior of the tumor itself, if we look at the natural history, or we look at the molecular basis of radiation therapy or radiobiological basis of the radiation therapy, and then chondrosarcoma is not a very sensitive tumor to the radiation therapy itself.
Okay, thank you. Any comments or questions from our listeners, other
So
participants?
is there significant residual disease left? Is it just very small residual?
हमारे पास पोस्ट ऑप स्कैन है क्या फातिमा?
सर, हमने अभी तक पोस्ट ऑप स्कैन नहीं कराया है पेशेंट का। हमने ग्रॉसली
बट ऑपरेटिव फाइंडिंग में हमारे पास सिग्निफिकेंट डिजीज
सर, ग्रॉसली हमने सारा ट्यूमर निकाल दिया था, बट अगेन द थिंग वाज कि वो बहुत, इट वाज वेरी क्लोज टू रेक्टम। दो हमें रेक्टल रिसेक्शन की जरूरत नहीं पड़ी थी, बट अगेन वहाँ पे अब बिकॉज इट वाज वेरी क्लोज एंड बिकॉज मेसेंकाइमल कॉन्ड्रोसार्कोमा है, तो श्योरली उसके माइक्रोस्कोपिक डिपॉजिट्स तो उधर होंगे। लेकिन जो है, हमने कोई पोस्ट ऑप स्कैन करा के कोई ग्रॉस डिजीज नहीं देखी। ग्रॉसली वो कंप्लीट रिसेक्शन था।
So, but do you plan to get post-op scan in like coming weeks or मतलब?
So sir, we were not planning to get a post-op
तो
scan.
पेट आपने करवाया, उसके बाद पेट स्कैन करवाया आपने, राइट? सर्जरी के बाद?
नहीं, पेट तो पहले नहीं हुआ था, पेट
बायोप्सी के
तो
बाद
से
कराया
पहले।
था। उसके बाद हमने फिर रिसेक्शन कर दिया। रिसेक्शन के बाद हमने अभी तक कोई भी स्कैन नहीं कराया।
अच्छा, तो पेट आपने सर्जरी से पहले करवाया?
यस सर, वो क्योंकि हम इनिशियली मेटास्टेटिक डिपॉजिट सस्पेक्ट कर रहे थे, तो हमें था अगर मेट्स हैं तो फिर तो सर्जरी नहीं बनती, फिर रिसेक्शन का कोई रोल नहीं होगा। फिर सिर्फ पेरिएटिव रिसेक्शन का रोल होगा। लेकिन क्योंकि वो मेटास्टेटिक डिपॉजिट नहीं था, इट वाज जस्ट सस्पेक्टेड डिपॉजिट और पेट स्कैन के अंदर वो नेगेटिव आ गया, तो फिर तो बिकॉज इट वाज मेसेंकाइमल कॉन्ड्रोसार्कोमा, तो प्राइमरी ट्रीटमेंट ही फिर रिसेक्शन थी, तो फिर दैट्स व्हाई वी वेंट फॉर रिसेक्शन.
So, Dr. Asim, in this scenario, then I think we will need post-op scans, right, for any further planning.
Yeah, irrespective of the, not in particular, every case who is got operated definitely need a post-operative scan to decide about the further management. The one thing is that what I would like to know about the histopathological finding, because it was not discussed. It was just mentioned that it is only the mesenchymal. Any other features that I mentioned in the histopathology report?
हम आपके लिए रिपोर्ट निकाल लेते हैं, फातिमा जरा रिपोर्ट देख के बता दें कि उसमें कोई और इस तरह के फीचर बताए हुए हैं. So, डॉक्टर साहब कोई और सवाल कोई, अभी आई कैन सी हियर वी हैव डॉक्टर सरमद भी हमारे साथ हैं. अस्सलाम वालेकुम सरमद. डॉक्टर महबूब फ्रॉम वाकन. अस्सलाम वालेकुम सर. ओके.
उन्होंने फीचर्स बताए हुए, मल्टीपल फीचर्स, मतलब मल्टीपल मार्कर्स बताए हैं, ट्यूमर मार्कर्स, जो CD99 और NKX 2.2, ये वाले सारे मार्कर्स बताए हुए हैं उन्होंने. डू यू वांट मी टू शेयर दोस मार्कर्स?
No, you don't need to actually share that thing. What about the grade that it may have mentioned
ग्रेड
about?
ग्रेड क्या बताया उन्होंने?
ग्रेड कुछ भी नहीं बताया हुआ सर, उन्होंने सिर्फ लिखा हुआ है फीचर्स फेवर मेसेंकाइमल कॉन्ड्रोसार्कोमा.
ठीक है.
So definitely this patient require actually the repeat scanning to see the status of the resection over there. The other thing that would require that we follow by the follow up with the medical oncologists and the radiation oncologists for consideration of further treatment.
Right. Perfect. ठीक. Thank you.
And Dr. Asim, sorry, Dr. Asim,
जी,
would
जी.
you think कि जो intra-abdominal intraperitoneal जो lymph node है, do we need to do a biopsy of it? Because I was thinking कि अगर it shows the same, metastatic lesion, because it could be anything. अभी तो हमारे साथ suspicion है ना. But if it is metastatic, then we definitely need to do, अगर residual है या नहीं है जो primary region के अंदर, do we need to radiate just for control, local control के लिए? But if this abdominal thing is something else, not related to that, and there is good local control surgically, then we can just observe.
So
I
the
think
ideal, so the ideal thing would be actually to evaluate that region as well, because sometimes there is a possibility that you may have, it may be possibility that it is only the benign condition and nothing to be worry about. But if you anything that is suspicious on the scanning is actually required for the workup. So I totally agree that this way the intra-abdominal component is also need to be evaluated, because sometimes if it is the same thing that we have talking about, then definitely the stage has changed. So if in the case of the metastatic disease, yes, you can the role of radiation therapy, you can actually consider, still you can consider, but it's not so obvious. And in that situation, we need to actually look at the more towards the systemic treatment rather than particularly for that. Because if you're talking about a metastatic setting, you can utilize radiation therapy to provide a local control. But as I mentioned, if it is a chondrosarcoma, chondrosarcoma per se is not very sensitive to radiation therapy itself. It always requires surgical excision and then radiation therapy for local control. So if you're talking about that thing to be suspicious of the same thing that we have already mentioned in our cases, then definitely also require the oxygen and those things. But the important thing is that if there anything that is suspicious of that thing, and that also require biopsy of that thing. So what about our radiology colleague? What they think about that particular component that they mentioned about the intra-abdominal part? Dr. Shayan, Dr. Shumaila.
Dr. Shayan.
I haven't reviewed that yet. If you can share the MR number, I can review right now.
Yeah, ma'am, sure. The MR number is 47872.
फातिमा यहाँ नहीं बोलो, उनको मैसेज कर दो प्लीज,
okay.
प्राइवेट मैसेज कर दो.
Sorry.
Okay, so meanwhile we are taking out the images. Any other comments, thoughts?
वन मोर थिंग, जब इनिशियली हमने एक और ये प्लान किया था कि हम इनकी सीटी गाइडेड बायोप्सी कराएं, तो वी वर टोल्ड कि इट विल बी अ वेरी हाई रिस्क बायोप्सी. So also if you can comment on it, if we go for biopsy, is it doable?
I think ये तो या तो इंटरवेंशन रेडियोलॉजिस्ट ने कहा, उन्होंने ही कहा होगा ना कि हाई
जी
रिस्क,
सर,
या जनरल
यस सर।
सर्जन, राइट? So you did think about biopsying this intra-abdominal lesion, right?
Yes sir, because initially जब हमें suspicion था कि whether it's a metastatic deposit or not, तो हमारे दो ही plans थे कि either we go for a PET scan or biopsy. But again, biopsy was because it was high risk, so we went for a PET scan.
Okay.
So the other thing is that what is the uptake level on the primary tumor, because we had this PET scan before the surgery. So what is the SUV score of the primary lesion? Any idea about that thing?
So किससे पूछ रहे हैं आप? फातिमा से?
Fatma, because we don't have the reports here,
Yes.
no? It is better if Fatma would comment on that thing, because this is one of the important thing, that if, for example, if the SUV of the lesion is very high in the primary side, and the other nodule that we are talking about is not at least as such taking any SUV, that it might be that there is other differential as well to that thing as so that is very important.
Can I share my screen?
Yeah, sure,
जी
doctor.
जी।
Is this visible?
जी।
All right, so I think this is the PET CT. So the one on the left are the PET images, in the middle are the CT images, and on the right are the fusion images. And then you can see, as I'm scrolling it down, this is the primary tumor. And this area which has been pointed out probably last on the image, this is not AV, FDG AVID. My arrow is on this lesion. Other than if you look at the PET images, I do not see any normal avidity anywhere other than that.
Right.
This is all bowel activity anterior to it.
Okay.
Thank you, Dr. Shan, for sharing things.
Thank
So
you.
looking at the PET scan, I don't think so. We there is any as such activity appreciated on the PET scan apart from the primary lesion that has been resected as well. So this patient require that this further that the post-operative imaging in order to actually have a better idea about the current status, followed by following with the radiation oncologists and medical oncologists for further treatment.
ठीक है सर। Perfect. So we go to the next case. I think हमारे इसमें थोड़ा सा time ज़्यादा लग गया है. Hamza, can you share your screen? Or should...
Sorry, sir, I don't have the presentation available.
अच्छा,
Could someone
फातिमा
please?
आप कर सकती हो? अच्छा, अगर फातिमा के पास भी नहीं है, तो let me try again if it works. Can you...
Yes, sir. Thank you.
Just a minute.
So this was
Okay.
this was a 34-year-old lady. She presented with KPS 80. She presented with headaches, vomiting, and left-sided weakness in the ER. An MRI brain was done, which showed multiple lung-enhancing lesions at the gray-white matter junctions in the supra and infraoral locations. The largest lesions were in the right frontal and the parietal regions, causing mass effect. She also had a CT chest, abdomen, pelvis with IV contrast done, which showed metastatic lesions in lungs, mediastinal lymph nodes, left adrenal gland, and the D8 vertebra. This is suspected to be metastatic right lung cancer, stage 4B. So her tumor markers were done. CA125, CA99 and CA and LDH were raised. So after discussion with oncologists and radiation oncologists in our hospital tumor board, we decided that because of the severe mass effect of those lesions, especially in the right frontal and the parietal regions, she would benefit from resection of them for benefit of brain tumor control. And then after that, we would decide for systemic chemoradiation. So she underwent neuronavigation guided right frontal and right parietal craniotomy, maximum safe resection of those lesions. So this is the preoperative scan, T2 axial weighted images, which show the lesion.
Right. So I think if Hamza, we can ask Dr. Shayan if she can
Yeah.
also... You can briefly describe, and then we can ask if she wants to add something. Yeah.
There's multiple infratentorial and supratentorial lesions. As we can see, there's a few on the left cerebellar, right cerebellar region, multiple small ones, much more appreciable on contrast imaging. But otherwise, the largest ones, which are causing midline shift and mass effect on the contrast scans, they're much more visible. 8 to 9 lesions were appreciated.
Right. So, Dr. Shayan, please let me know if you want to add something.
Yeah, I agree. Move on.
Right. So, इसकी बायोप्सी हो गई है ना हमजा?
Yes, sir.
तो आपने कौन से उनके लीजन को आपने रिसेक्ट किया है?
Sir, we went for the right frontal and the right parietal lesions. We did a maximum safe resection of them. And it was reported as metastatic adenocarcinoma with cribriform patterns likely to be of lung in origin. So this case was signed as metastatic lung carcinoma.
Okay.
और हमसे इसमें लंग की अभी तक हुई है बायोप्सी जो लंग मास वगैरह था?
Ji, sir. So the largest lesions were actually in their right side, right hilum, I remember. And so the strange thing is that she had no significant smoking history. She's a 34-year-old female, no other comorbid, but she has a significant family history for multiple cancers. On her paternal and maternal side, mostly blood and GI cancers. But she had no other previous history, but however, she did develop this.
So उसकी pathology में if it's small cell lung cancer, I don't know small cell था या कौन सा था, because if it's small cell, मेरे ख्याल में तो फिर उसमें brain lesion की biopsy की जरूरत नहीं होती. They are very sensitive for radiation in that case. So whole brain radiation would have done the job. But if it's not small cell lung cancer, फिर उसमें ये है कि you take the big lesions out brain की जो है.
Sir, it wasn't reported as either small cell or non-small cell. I think the primary issue, sir, was that she was presenting with disorientation, and the oncologist was worried that because the most disease was present with, they were worried that overall survival was dependent on control of the brain disease particularly.
So Hamza, what's the histopathology report says?
Sir, it's been reported as metastatic adenocarcinoma with cribriform pattern with lung primary site of tumor origin.
So when you're talking about the adenocarcinoma falls under the category of non-small cell lung cancer. So it is not a small cell lung cancer itself. So we are talking about the non-small cell lung cancer, number one thing. The other thing to have mentioned about the multiple, the staging work on finding that this patient also has adrenal nodules as well as the Puni disease as well as the brain lesion as well. So usually, if a patient has a stage 4 disease to begin with, do you have the curves of this primary site or CT scan of primary area?
We do have it on system. Should I
Okay,
share
you
it?
don't have it in it. Oh, it's all right. Do you have a time for testing?
It's the time to have, sorry, I got disconnected again. We have like 10 minutes.
So if Dr. Sharon, you kindly if you share the CT scan of this patient, so we might have a clear idea about extent of disease, and the question that asked by Dr. Saad would be pertinent here as well.
So Hamza,
Sure.
I missed your point. आपने कौन सा lesion resect किया है? It's
So
right
right
का, right?
frontal and right parietal.
Both
Yes, sir.
with two different incisions.
Ji, sir.
Okay. Okay.
Should I share the MR number with Dr. Shayan for the CT scan?
हमने डॉक्टर शयान को आज ज्यादा काम
Yes,
दे
please
दिया.
do. Yes, please do. I have my act open.
Okay, thank you, Dr. Shayan, for this help because we were not planning. It's just happening
Thank you, ma'am.
spontaneously.
Not a problem.
So, can I ask? We have Dr. Saad bin Anis from Shaukat Khanam, Dr. Mehboob also from Wakant, and so in your centers in these cases, what will be your thoughts? Like, will you go for a section like X lesion code, both, or you just like think about which one is causing the most significant, or will you operate or will you not operate? Like, that's another thing.
So as at our center, we have this brain met pathway, which is solely it's not necessarily clinical, but ज़्यादा हमारा जो के protocol जो बनाया हुआ है for better management of all the patients के उसमें ये है कि if patients KPS is 70 or below, but इसमें तो 80 था, and patient has more than 4 metastases in brain, then we don't offer surgery.
Okay.
चाहे जितना मर्जी बड़ा lesion हो या छोटा lesion हो, we don't offer surgery. We give you this, radiation or the best supportive management उससे पे चल जाता है. If there are less than 4 lesions and patient KPS is good, then we consider surgery depending on if it is easily accessible or not. But I guess solitary lesion, or then we always solitary or those lesions, we
Right,
always
right.
go.
Good, thanks. Interesting.
So I hope my screen is visible.
जी, Dr. Shahnaz Rari.
All right, so you can see that this is a large necrotic mass, which is in the right upper lobe, and it is closely abutting the mediastinum. And it is kind of encasing the upper lobe bronchus and the the right pulmonary artery as well. There's a large necrotic node in the right hilum. Again, we can see necrotic lymph nodes in the subcarinal region. There's kind of some atelectasis in the right upper lobe as well, subsegmental. And if you go to the bone window, you can see this is a deposit here in the T8 vertebra. Other than that, in the soft tissue window, you can see there's a large necrotic deposit in the adrenal gland, very typical of a lung cancer. And if you look at the lung window, this is within the lung parenchyma. You can also see some soft tissue nodules or satellite lesions in the adjacent parenchyma. It may be just pneumonitis. no discrete nodule to suggest contralateral metastasis probably. So typical of bronchogenic carcinoma.
Okay.
So we are so if you are talking about the metastatic non-small
Consider
cell
whole
lung
brain
cancer.
radiation in this patient?
Yeah, no, I'll
Sorry,
come
doctor.
back. So when you're talking about the management of non-small cell lung cancer patient, particularly when we're talking about a stage 4 patient, the stage 4 patient is usually started with a systemic treatment. But the role of radiation therapy is only if there is a lesion that will actually cause symptoms. So particularly in this patient, because this patient has two lesions, one in the brain is involved by the multiple lesion, and the other is portable body. So both these sites actually require the radiation therapy. What is the power status of the patient? Because the lesion at the dorsal vertebra look very suspicious for compression on the cord. So any idea about the
हमजा
power?
इनकी पावर क्या थी?
No, sir. So she has no lower limb weakness. Her left upper limb was slightly weak, 4+/5, but post-operatively she's developed no new neurological deficits.
Okay. So this patient require radiation therapy to both the spine, the dorsal vertebrae, as well as the whole brain. So usually, if the patient has multiple brain lesion, usually the management is whole brain radiation therapy. How in cases where there is a mass effect, then definitely surgery has a role actually to, particularly if the patient has a good performance status as well. Then definitely patient has there's a role of surgical excision or debulking or decompression of that lesion. So we provide a better quality of life to that particular patient, because sometimes what happens when you started with the radiation therapy, because the lesion is already big, so it may cause further edema or worsen the situation. So in that situation, surgical decompression would actually help. But again, the performance status is very important thing, because irrespective of all these things, the one of the key factor in the management of non-small cell lung cancer is a performance, whether we are talking about the selection of patient for radiation therapy or selection of patient for surgical excision or any other management plan. Definitely the performance status has a key importance. So that I think would be definitely considered in mind before offering any treatment.
Okay. Thanks. Any questions, comments from our participants? Okay.
Dr. Essen, thank you. Just a question: with this kind of extensive disease involving multiple systems, can we leave it alone?
I think it's a very pertinent question, and आपकी बात बिल्कुल सही है. And I think different centers have different, I would say, their protocol. So yes, there is a
So
एक
may I?
bias होगा क्या? Yes.
So the Dr. Mehboob, you had raised a very pertinent question. The important thing, as I mentioned earlier, because the performance status, because she is a young patient with a good KPS. So in this kind of patient, actually denying any sort of treatment is, I don't think so, is a good option and at all. But definitely the patient who has an elderly patient who has a severe metastatic, widespread metastatic disease and has very poor performance status, and not a candidate for any treatment at all. Definitely one of the option is that definitely for the supportive care or the supportive care only. But considering particularly in this case, considering the age of the patient, the other thing is that considering the performance state of the patient, and the other thing is that we have a lot of treatment option available for this kind of tumor. So particularly from the systemic end, though I am not an expert or from the medical oncology point of view, but there are systemic treatment available. So one can actually discuss different treatment options. Depending upon the response of the treatment to the systemic treatment, one can think of what we have said earlier. but just at the beginning of the treatment, this is one of the options you can actually discuss with the patient, but usually it lies very low in the order, rather in the treatment option order rather than at the front. But definitely the KPS and the patient performance status is the most important factor, as mentioned earlier, in decision making process.
So is there any role of a genetic workup and targeted treatment in this case, particularly considering there's a background history of family history, known cancers?
Definitely, Dr. Shana, we don't have any medical oncologists. Do we have any medical oncologists here?
आज नहीं है sir हमारे पास वो
ठीक है. But usually what happened in this, because the paradigm of systemic treatment or the management of the lung cell cancer has changed dramatically over the period of time, over the last decade or so. So now we are talking more about the targeted therapy, the genetic thing, because as I mentioned by Hamza, that previously this patient also had a history of a strong family history of multiple cancer in the family members. So definitely this patient requires genetic as well, the testing family also requires the genetic testing as well. But the other thing would definitely, because as mentioned, now the patient have different option in terms of, so there are different markers that need to be checked to be so targeted treatment can be offered accordingly. So definitely all these things. So that's why it is necessary to have a follow with the medical oncologist. So different treatment option can be discussed with the patient, and also the different molecular markers that need to be checked before offering treatment can also be checked and discussed with the family, and then proceed from there. So this patient requires definitely the follow up with both the radiation and the medical oncology, because there is a brain lesion, and while that these all tests would be actually come up, it is better to start with the brain radiation therapy and the radiation to the spine, so that it finished before the treatment systemic treatment is started.
Right. Okay. So if we do not have any further comments or any questions, so we just had 2 cases, and apologies for the unstable connection cases. And I would also request all our participants to bring their cases from their centers, and then we can discuss how things are being managed in different centers, and we learn from each other. And I think that's the most important thing, and that's the main objective of this meeting, that we continue to learn from each other's experience.